Okay, thank you very much to the three ETN fellows for their presentations. We will now start the discussion of each of the presentations. The first being the presentation by Luis Fernandez on the impact on clinical environment on surgeons' treatment choices. And I will start by giving the word to Professor Mauro Laudicella.
Okay, thanks, Kim. Thanks, Louis, for this very interesting presentation on this study. I would like to focus the first item for the discussion on something about the policy relevance of the study and the context where to read the results of the study. So, for example, in terms of the impact of the environment on the decision of the surgeon, this study seems to point that the surgeon seems to adapt quite easily to the new environment. And it seems that the environment is affecting the surgeon practice style much more than the practice style of the surgeon affecting the environment. But in order to read this evidence correctly, I think we should think also on the context of the study in terms of what the cost of the behavioral change that may or may not happen in the practice style of the surgeon in this case, and what is the difference between the two technologies in terms of costs and outcomes. So if you would like to give us some input on this direction, in order then to be able to say, okay, so for examples of procedures and technologies that have these characteristics, then we may expect something similar to the evidence that you have produced with your study.
Okay, so in terms of direction, and what I think is relevant in this paper is that firstly, the choice of both methods of procedures, they are not driven by the way that hospitals are reimbursed for that procedure, which means there is no financial incentive to choose one over the other one. And so I think that that's quite relevant, because it allows us to purge the analysis from this financial incentive that can happen. The other thing that is relevant is the fact that there are no clear guidelines driving this decision. And so what that matters is that what that is suggested is that the choice is mainly driven by characteristics of the hospitals and by characteristics of the surgeons that perform the surgery. And here in characteristics of the hospitals, we can think of differences in technology or differences in constraints that hospitals have, different financial constraints, or more relevant, and I think this is quite important, is that there might exist some peer pressure in this new environment where the surgeons that work in the new hospital, they might have something more to say on how these procedures are done in a certain hospital. And of course, on the side of the surgeon, what is relevant here is the fact that he has a background, he has a training, he has his preferences and his beliefs. And so this is going to collect with the differences that he finds in the new environment.
Okay, those are all good points. My question on top of this initial discussion is if you think that the circumstances of this particular case, like the cemented, uncemented hip, in particular, the fact that the learning cost for the surgeon is zero or very low, and the fact that so he already knows the other type of procedure, and the fact that these two procedures seems to be quite equivalent in terms of cost to the hospitals and outcomes to the patients, do you think they may determine such a rapid adaptation of the surgeon to the new environment when he moves?
They may, sorry, could you repeat?
So if they may be determinant in terms of like how quick the surgeon decide to adapt to the new environment, and on the fact also that the surgeon decide to take in the culture that is already in the environment where he's going, rather than try to keep his own background and, you know, stay with the same practice style in a different environment. I was wondering if you think that these two elements may be key in reading the evidence that you have produced with this study.
Yeah, sorry, because I couldn't hear the.
Okay, I'll rephrase this. Yeah. So I was wondering if, in terms of the evidence, I think the main evidence here seems to be that surgeon moving to a new environment take in the new environment, and so it changes the practice style and adapt to the environment. And in order to extrapolate and apply these results to other cases instead of cemented, uncemented hip replacement, what are the elements that we should look for in order to say, okay, these results are applicable to, for example, another type of intervention, technology, or treatment? And I was reading in two elements as, for example, the fact that the learning cost is very low, and the fact that the two treatments are equivalent. If those are like two key elements for these results to be applicable to other interventions or treatments or technologies inside a hospital.
And definitely those two factors that you mentioned, they are relevant for the results that we find, because there isn't a cost to adapt, because surgeons are already trained in that other procedure.
What about the two other studies that you mentioned, the US studies? Are there some information there that can be put forward?
Well, so one of the papers from the US and the one from Malta is very, very close to ours in terms of methodology. The novelty that we provide is, in fact, what I just said, that we are purged. We purge the analysis from financial incentives, and the clinical guidelines are not very clear. So those were two things that improved this literature and the results from the US. I mean, I think it's quite difficult on changing how some factors change between settings. I mean, going from this decision on cemented and cementless to some other decision, since there are all these factors that I just mentioned that could be at play. Importantly, if there are clinical guidelines, those could be quite relevant in driving the decision. So, yeah, I'm not sure I'm answering the question, but maybe I'm not also understanding it properly. So if you'd like to develop a little bit, maybe.
I think we have time for one more question. And Mauro, if you have one more question, you can. Otherwise, I have one that I can.
I would like. Yeah, another question I think that was very interesting in the study is the topic of the short term and the long term. So the fact that you mentioned that in the short term, it seems that the environment takes over with respect to the individual practice style of the surgeon who moves hospitals. And then you mentioned something about the long term, and I wonder, like, if you want to expand something on what your expectations are on effect on a long term. If on the long term this can have a different direction, or it may follow actually in the same direction.
So yeah, so what we test for in our analysis and that we show is that the surgeon who moves quite quickly absorbs the environment, and maybe we would expect for him to slowly, like endogenously, slowly adapt to this new environment by Bayesian learning process, in the way that he's gonna be adapting all his preferences and beliefs. And what we see is that after the move, so they change quite quickly, and that means that the environment is taking place on driving the decision, because physician factors are all fixed when they move. And we see that after the move, the result remains flat, and that's what indicates that we don't see, so our horizon of course is short, so we would like to have longer horizons to understand what happens in the long term. But first, the fact that it changes quite quickly in the short term indicates that the environment could be a priority in terms of policy. But we would expect, and this is suggested in the literature, is that slowly surgeons might in the long term update their beliefs and preferences, which of course come from the time that they start practicing during that postgraduate training. And so slowly they have developed all these preferences and skills that they have. And so in the long term, this could happen. However, since our horizon is quite short, we cannot observe this, but that might happen in the future, and has been shown in the literature.
Okay, I think that we have to move on to the next presentation. Maybe one last question, and that should be answered very shortly. Do you have any ideas for what would be an obvious future research topic within this area?
Yes. So very briefly, of course, like what the previous paper did is that they separated this demand and supply side component. And so we start looking at what's inside this supply side component. And so, of course, forward, we would like to understand better effects within the environment that drive the choice. And this is something, as I mentioned, for instance, peer effects, or the effects of the other surgeons, how do they drive the behavior of a certain consultant. That's something that I think is crucial to look at in the future.
Okay, thank you very much.
Thank you very much.
We'll move on to the next presentation. Yes, and welcome back. Now we want to move forward to the second presentation by Brian Bulleblanc on impacts of an integrated electronic health record disease management program for type 2 diabetes patients in Denmark. And this study is focusing on behavior and incentives for general practitioners. And let me start by giving the word to Mauro.
All right, thank you. Thanks, Kim. It was a very interesting presentation. I would like to open the discussion on something related to the motivations and the incentive that drives the physicians here in the performance that you assess with the study. So, if what are your opinions, informed opinions that you made up through these studies in terms of like what kind of mechanisms are better and effective into pushing change in behavior?
Wow. I think, I mean, in the context of this electronic healthcare record system, there's this non-financial aspect, this competitive, well, potentially competitive feedback mechanism, which was sort of on the back end of this electronic healthcare record system, where different GPs could see how they were performing relative to other GPs treating the same groups of patients, as it were. I'm curious. I actually don't know to what extent that may have motivated GPs to change actual treatment behaviors. I mean, there certainly is good reason to think that GPs tend to be quite highly competitive people and motivated in these sorts of directions. You have to be quite highly motivated to even get into medical school and to go down this line. I guess that my hesitancy in this case to attribute a great deal of behavioral change to that sort of non-financial incentive is that we know that not everybody was using the system at a high level. And in order for those metrics to be really meaningful, I think everybody has to be using the system at a similar level in the first place in order to be able to make a fair judgment about how you are performing relative to another in terms of caring for a group of patients. So that's one sort of take-home point that I would bring up when you're talking about non-financial incentives and aspects related to this particular disease management program.
So are you saying, for example, that it's maybe not so much about the relative performance, so like assessing yourself against somebody else, but for example, just giving a tool to make the job better, could be enough?
I think that the potential positive impact on treatment of patients has more to do with just presenting better information rather than tapping into this competitive nature. I mean, I think GPs are good people. They want to do well for the patients, and they may not be aware of when they're falling behind on caring for particular patients. And so by providing them a structured information system, which can highlight where care is perhaps falling behind with respect to specific patients, I think that sort of non-financial incentive is much more likely, at least in this case, to have had a significant impact on the care of patients. And of course, in the case of this disease management program, it really was designed to identify patients who are falling behind and to provide red flags beside particular patients, saying this patient has not had their annual checkup, or the last time we had a visit and we did our blood tests, they were on a bad trend, for example. Maybe we need to make some extra efforts to get that patient back here and have another follow-up. I think that that's not a financial incentive, it's a non-financial incentive, but I think in this case, it's more likely to have driven the apparent benefits on changes in treatment patterns that we seem to observe. Does that answer,
that's a very interesting discussion. I think it points to the direction where simply by giving like more adequate tools for physicians to do their job, it could be enough for them to then have a better performance.
I think that so another thing which I think is that any change in performance is going to be relative to what the baseline situation is. And while we actually, we have a fairly good idea about what this electronic healthcare record system was and what it could provide, there isn't a clear understanding of what it was replacing. And I think that if you're trying to make statements about what's really important, what's most influential for driving some sort of change, you do have to have quite a clear understanding of what the new thing that you are considering is replacing, and that's a sort of a missing part from this particular piece of research.
Yeah. So maybe I think that there is scope for one more question, Mauro, if you have that, or a discussion point. Otherwise,
okay. Yes, I think another question is in terms of the effects on cost of this particular reform. What is your vision in terms of the short-term effects and the long-term effects? Like, which kind of effects would you expect to be more visible during the short term and then long term?
So I think in the short term, you're likely to see an increase in costs in the sort of primary care sector, which is where the system existed. And you would hope to see that, because if it was making any sort of impact, it was probably driving an increase in care. It's not going to be giving a signal to GPs that they need to provide less care to any particular patient. I think it's really only going to go the opposite way in encouraging more care in the primary care sector. By improving the primary care sector, as with other ambulatory care sensitive conditions, you hope to, over time, reduce the rates of hospitalizations. But that's not something that you would expect to happen in a short period of a couple of years with a chronic disease such as diabetes. It's an unfortunate reality that the system was discontinued after only a few years, and so you can't really know the long-term.
And on top of that, the learning curve for a GP to be efficient in using the system could also maybe have some further effects in the long term, like if after 1, 2, 3 years, when more GPs become efficient in using the new electronic records, perhaps the effect of the short run can be amplified.
I think that's a fair point. I think that is a fair point. I mean, of course, the effect that we observe is you know, it's GPs who are using the system at a high level to GPs who are basically not using the system at all. And, you know, but that's not the effect that society cares about. Society cares about the aggregated effect across all GPs over time. And that's only going to happen after many years in which the system is rolled out and used basically everywhere. So that's the effect that society actually cares about, not this effect that we're able to identify based on a few years of observations.
So in that sense, the fact that the system was discontinued, it's a bit of a shame. It's a bit of a lost opportunity.
Absolutely, absolutely. Yeah.
Okay, I think we don't have time for more discussions, but maybe one last that you should reflect upon very short, Brian, is that this study was carried out on diabetes patients, which I guess is probably well treated in Denmark. So
yeah.
Some reflection on the use of this kind of incentives on other patients.
Well, I think that's a very good point. I mean, Denmark just historically, for a lot of reasons, has had a history of high quality care of type 2 diabetes patients in general. But if you are able to show an impact with a well-treated group of patients in a country like Denmark, it's likely that providing similar sort of information technologies to GPs for the care of patients with other chronic diseases, which are presumably not as well treated for society, the scope to make a positive impact is larger, I think. So I think that this, in some respects, is a sort of a low limit, like a low threshold case where you might observe some sort of change.
Okay, thank you very much. Thank you for a good presentation and an interesting study. Let's move forward to the third presentation.
Okay, thanks a lot. Take care.
Bye. Yes, and now we will begin the discussion of the third presentation, the presentation by ETN fellow Olsen, which is on the comparison of strategies to attract blood donors. And I will start by giving the word to you, Mario.
Okay, thank you, Tim. Very interesting piece of work. I would like to start this discussion on something that relates to the motivations of the people who participate in the two programs. And in terms of motivations, I mean, what prompt individuals to donate, and what actually motivate the promoters to contact the individuals so there seems to be some differences in the two settings. Like one seems to be having some kind of reward that is not that is completely separated from the donation itself, and the other one seems more on the internal motivations of agents and perhaps also of the people that get that agree to donate.
Yeah, sure. Yeah, I mean, they are slightly different events, and the motivations could be a bit different. I think in both events we have this sort of group motivation that your group of friends are donating at the time, and it sort of motivates you to, or encourages you to come along and to motivate and motivates you to donate. And I think it's the same a bit with the action week. I sort of imagine when the students are going around, so they're approaching groups of people, and one is saying kind of, yeah, let's sign up for the event, and sort of encouraging their friends to do the same. But it could be a bit more. It's also a little bit different that for the bikers at the event, they're donating on the day, and everyone is watching them donate in their community, and that could be a bit different to sort of the action week, where they're just signing up to donate, and then later they go and actually donate. So the sort of framing of the interventions a little bit different.
But do you think so in these terms, do you think this different type of motivation can have different contributions in terms of the success and the cost of the two different programs?
I mean, we see the sort of in both events we have similar outcomes in terms of number of donations, so that would sort of suggest that they are similarly effective. But yeah, I couldn't say sort of give an answer on whether they sort of are acting different mechanisms.
So in terms, so if I can expand on this, it's something to do with do we need some kind of reward that motivates people in terms of either donate or promoting donations, in terms of approaching other people and trying to convince them to donate, or it's something that can actually be effectively can be achieved also without any kind of external reward, just selecting those people that those students may have internal motivation that just push them to perform equally as those that instead seems to have some kind of reward. There was this bikers event. I assume that some of this cost of the event were taken from by the hospital or by the beneficiary of the donation.
Yes, so the costs are sort of, it's run in collaboration, the hospital and the bikers themselves put some money towards the event. Yeah.
Okay, I think we will have time for one more point from you, Mauro, and before that I'll just raise one discussion point, and then the last one from you, Mauro, and then I think we'll have to finish.
Okay, so in terms of if you had to plan a third program, if you would be having to plan a third program for collecting donation, how would you from the lessons that you learned from these two different programs that you examined, what are the elements that you think should be included in a successful program that promotes donation?
Okay, I think I hinted at sort of a little bit in the presentation. So we have the Action Week event, which was sort of really financially viable. But sort of focusing a bit more on the second time donors would be sort of really, I think, more interesting, sort of tap into the kind of donors that they would require. So I think, as I mentioned, sort of as they leave the donation centre, getting them sort of to sign up for coming again in 3 months' time. I think that could be an interesting strategy. Yeah, I think that could work. Yeah.
Yeah, so maybe a follow-up question on that, because it seems that if you want to keep the donors being loyal to the program one way or another, is there any studies that use some kind of nudging or something to such that they buy, so that if they don't refuse to come again, they get an invitation for coming again some weeks later? Is there any evidence on nudging working on this group of
there's evidence that sort of reminder emails, reminder telephone calls can be effective, but the evidence is quite mixed. What they find is actually quite difficult to get donors to come back, and it's really sort of getting donors to self-motivate to form habits, and I think that's the kind of the main aim, but in practice it's not that easy to do. But I think it's probably the reminder emails that would be the most effective. So perhaps that could be part of the intervention as well, that sort of they sign up for coming again, and then they receive a reminder email or phone call, sort of getting them to validate or to sort of to actually come back and follow up on their promise.
Okay, I think we have to close for here. So thank you, both of you, for a good discussion, and thank you for a good presentation, Olsen. So this will end the session on behavioral incentives. Thank you very much.
Thank you.